Hi there, welcome to tonight's live stream webinar here at NASS. My name is Zoe Clark, I'm Programme Manager, and I'm delighted to be joined by Dr. Matthew Roberts this evening, who is a research scientist. Hi Matt, how are you?
I'm good, how are you?
Good, yeah, good, thank you. So pleased you're joining us. I'm really excited about this session. I think it's going to be a really interesting topic, and we've already had lots of questions in, which is a great sign as well.
No, thank you for inviting me. It should be good.
You're welcome, yeah. So do you want to, before we get started, do you want to tell us a little bit about yourself and then we'll head into the presentation?
Yeah, so I'm Matthew Roberts. I've been doing research for probably around 8 years now. Since 2020, we've more delved into inflammatory diseases, including axial spondyloarthritis. And I'm based at Loughborough University and I'm funded by the Leicester Biomedical Research Centre. So all of our research which we do is focused on lifestyle management of conditions. And I'll be sharing some of the research today into axial spondyloarthritis.
Brilliant. Yeah, really looking forward to it. Thank you so much for your time this evening. So for everyone who's joining us live, please do pop any questions or comments in the comment section. What we'll do is Matt will have a presentation and then we'll come for a Q&A afterwards. So if you have any questions at all, please do pop them in there. And also please share your experiences as well. It's always really good when we're chatting about physical activity to hear other people's experiences and your tips, things you found helpful as well. So do get the conversation started in there. And for anybody who can't join the whole session, you can come back and catch up on the recording afterwards. And we'll keep an eye on the comments over the following few days. So if you're watching us on catch up, please feel free to pop any questions or comments in there and I'll keep an eye on those too. So I think that's everything from my side. Are you ready to get started, Matt?
Yeah, I'll just share my screen.
Wonderful. And then after your presentation, we'll come to the Q&A and answer as many questions as we can fit into the time.
Great.
Brilliant. So I'll just add your slides there and hopefully you can see those.
So let me just get my pointer up. So can you see this?
Yep, perfect. That's great from my end. So I'll hide my camera and I'll come back for the Q&A. Thank you.
Perfect, thank you. Yeah, so hi everyone. I'm Dr. Matthew Roberts, and today we'll talk about exercise as an anti-inflammatory management for people living with axial spondyloarthritis. The talk is going to be around 25 minutes, and then we'll have some discussion at the end with a chance to answer any questions as well. So although I'm presenting, it's very much a team effort, and all of these people were involved with our research. You've got Dr. Morphy at the top there, who's a consultant rheumatologist, and Professor Bishop in the top right, who's really a leading expert in exercise immunology, so looking at the exercise effects on the immune system and inflammatory conditions. And at the bottom there are the PhD students who have supported this research as well and are very hard working in the lab. So this presentation, we're going to do an overview of axial spondyloarthritis, looking at kind of the causes behind it, the prevalence and the current management. And then really the topic of this is to look at the contribution of inflammation and the role of the immune system, because both of them are very, very important to the background of axial spondyloarthritis. We'll then touch upon all of our current research, including lab-based studies, and discuss our patient feedback, including dropout rates and key quotes. So axial spondyloarthritis, if you go to the general public and ask them, have you ever heard of this condition? Most people have not heard of it. So 91% of the UK population have never heard of it. And they say, what on earth is it? It must be really rare. So let's talk about that now. So axial spondyloarthritis is a painful, progressive, inflammatory arthritis with the main symptom being back pain. It typically affects the axial skeleton, so that's the spine, the neck, and the head. And it can also affect the peripheral joints as well, so the hands and the feet. So it includes ankylosing spondylitis, which is when it's confirmed through scans, so things like MRI scans. And it also includes non-radiographic axial spondyloarthritis. So AxSpA is this umbrella term that covers both. Now, for the people who aren't familiar with this, I want you to just think about which age group do you think is this impacting? Because when you think about arthritis, typically you think about the older population, and we're going to get onto that. Now, at the bottom, what you can see is this kind of process that underlies the condition. So emphasis is where things, so it could be muscles, tendons, or ligaments attached to a bone. And effectively what happens is you get some sort of micro trauma or inflammation of that specific location, which attracts immune cells to the area, causing inflammation. And this stimulates a healing process, so bone formation. And what can happen with axial spondyloarthritis is actually the spine is made up of vertebrae that should be able to do this. So if you move side to side or front and backwards, your spine should be flexible and move with it. But what happens over time is the vertebrae can actually fuse together, so you can't bend it anymore. And that's what causes the stiffness in the spine. And that repetition over time starts to fuse the spine together, and it's associated with things like pain and extreme fatigue. So when we think about the age group, normally when you talk about arthritis, people think about an elderly population. But axial spondyloarthritis is quite unique because, as you can see in these images, it affects people from all walks of life. And the interesting thing is it's been termed an invisible condition because people on very good days with axial spondyloarthritis, you would never know that they've got axial spondyloarthritis. They'll go to the gym, they'll be walking fine, and you'll have no idea. But on bad days with flares, the symptoms of pain and fatigue and a lot of spinal pain can really be debilitating. So it affects around 1% of the UK population. It's double that of Parkinson's and multiple sclerosis combined, which is quite surprising because most people have heard of Parkinson's and MS, but it actually might be much higher. Now, the reasons for that is that symptoms commonly appear when people are in their 20s or 30s, and the average age is 24. But if you can imagine, if you go to the GP, for example, in your 20s and 30s with back pain, it can commonly get misdiagnosed for something like a slipped disc or a pulled back, a pulled muscle. And consequently, the median age or the median time it takes to diagnose SpA is 8.5 years. So that's from the point of having the symptoms to getting a diagnosis. On average, it takes 8.5 years, mainly because it's very hard to diagnose. It relies on physical examination and for the condition to progress, blood tests, imaging tests. But we know that a genetic marker is associated with SpA called HLA-B27. So if there's anyone in the audience with SpA, chances are you've been tested for HLA-B27. If you're positive for HLA-B27, that's highly associated with getting SpA, but it's not causal because you can have SpA and be negative for that gene. So it's just associated with it. Now, what we're really interested in is the comorbidities associated with axial spondyloarthritis, because that inflammatory condition underpinning the SpA contributes to all sorts of other conditions. So, for example, heart attacks are 52% higher in people with SpA compared to the general population, strokes 21% higher. And when you look at things like mental health, because of the pain and fatigue causing things like social isolation, anxiety and depression are 600% higher in people with SpA compared to the general population. Because of this as well, there's a societal cost. So many people with axial spondyloarthritis will work part-time due to fatigue and pain. And the annual cost to the person has been estimated to be around £9,000. And the annual drug costs, the medication costs, are about £8,300 for the healthcare provider. And there's these comorbidities which are associated with axial spondyloarthritis due to the inflammatory underpinning of it. So psoriasis, diabetes, uveitis, which is eye conditions, bowel disease, liver disease, and hypertension, which is blood pressure. Now, what we're interested in as well is the role of the immune system. And let me just explain this. I know it can look a bit daunting. In your body, you've got loads of different types of immune cells. But one of the cells which we're particularly interested in are these ones called monocytes. People who've got no conditions at all have got monocytes, and people who have got conditions have got monocytes. Everybody's got monocytes. But importantly, there's three subsets of monocytes. You've got these classicals, intermediates, and non-classicals, which you can see up in the top left. Now, this is really important. On your cells, effectively, they've got little identity markers, and classicals only express this marker called CD14, which is interpreted by this question mark icon. Intermediates have got a lot of CD14 and a bit of CD16. Okay, so that's a different marker on its surface. And your non-classicals have got a bit of CD14 and a bit of CD16. Now, all monocytes are part of what we call the innate immune system. So they're not really specific to a certain virus. And what they are is your frontline soldiers. So if they see something that they don't like in your body, they'll just go and attack it. And what they'll do as well is they'll tell other immune cells to come and help. So it's your first line of soldiers in your immune system. But importantly, the non-classicals and the intermediates, so these ones which express this receptor CD16, are incredibly pro-inflammatory. So when they notice something which they don't like, they'll start to release loads of pro-inflammatory proteins into your body, or molecules. So if you've ever heard of something called interleukin-6, which you may or may not have heard of, that is produced by these cells. Okay, and that's pro-inflammatory. It goes around the body causing inflammation. Now, what we know is that in populations with conditions, so things like heart disease, obesity, kidney disease, axial spondyloarthritis, which we'll get onto, the proportion of these CD16 cells increases massively. So in a healthy population, you can see here you've got positive CD16 cells and positive CD14 cells, and these are the two subgroups which we're really interested in. In a healthy population, your non-classicals will be about 10%, and your intermediates will be about 5%. Okay, so they're the pro-inflammatory ones. And we'll get onto what this looks like in people with axial spondyloarthritis, because that is what we've characterized in the lab. Now, the important thing with monocytes and the immune system in general is we call it highly plastic. So what that means is that your immune system can be modified quite highly through lifestyle modification. So for example, physical activity has been shown to reduce the proportion of these pro-inflammatory cells. And that is what we're going to get onto in this presentation. So what we know about physical activity is that high levels of physical activity is associated with reduced blood markers of chronic inflammation. So that's things like CRP, interleukin-6, and something called TNF-alpha. They're all markers of inflammation in your body. And we know that regular structured exercise can reduce the pro-inflammatory monocyte phenotype. So those CD16 positive cells which we're talking about, you can reduce the proportion of them with exercise, which in theory reduces the source of the inflammation. What we also know from research we've done at Loughborough, this was in a healthy population, but single sessions of structured exercise actually reduce the migration. So the monocytes are in your blood, and what they can do is they move out of your bloodstream and into surrounding tissues. So for example, if you've got inflammation that's happening in your spine, your monocytes will migrate to that area, which causes even more problems because effectively it's going to really inflame that area. So if regular structured exercise can actually reduce the movement of the immune cells into the area of inflammation. And what you can see on the right-hand side here, many of you might be familiar with CRP because it's routinely done in clinic. But the key message, which we're going to be talking about, is actually the benefits of exercise are seen in people who do no exercise compared to people who just do a little bit of exercise. So this population isn't in a population with axial spondyloarthritis, it's in a population with rheumatoid arthritis. And what you can see on the top panel is daily steps. And people typically aim for a daily step count of around 10,000. You've seen that in the news and everywhere. But what you notice is the people who are doing 0 steps compared to people who are probably doing 1,000 or 2,000 steps, they get the biggest reduction in CRP. And CRP is a marker of inflammation in the body. MVPA is moderate to vigorous physical activity. And again, what you can see is that the people who are doing no minutes compared to the people who are doing about 5 minutes a day, they're seeing the largest reductions in CRP as well. So this is suggesting that the biggest benefits of physical activity are seen in the people who are doing a bit of exercise compared to no exercise. And actually, if you compare people who are pretty moderately active, so around 7,000 steps, to people who are very, very active, so 25,000 steps, actually, there's not really an additional benefit. The big benefit's seen at the bottom down here. So based on that, you would think that the guidance for axial spondyloarthritis being an inflammatory condition would be focused around lifestyle modification. And here's the official recommendations for people with AxSpA. And what you can see is that the proportion of people meeting the physical activity guidelines, these are the World Health Organization guidelines, is 20% lower than the general population. So that's about 150 minutes of exercise per week. And I don't think that's surprising in this group, because when you look at the recommendations, you'll notice that many of these are focused on pharmacological treatments, so medications. In here, you've got this one bit of advice on lifestyle. So patients should be educated about AxSpA and encouraged to exercise on a regular basis and to stop smoking, and that physiotherapy should be considered. But what on earth does that mean? Because it's so vague. Do you do swimming? Do you do walking? How much exercise do you do? Do you exercise if you've got a flare? Do you exercise if you've got high pain, etc.? And what we know from speaking to people that have come into our labs is that there's this treatment pathway where initially people should be offered physiotherapy, and then they should be progressed onto non-steroidal anti-inflammatory drugs. And if they're not effective, then you should be progressed onto biologic medication. And biologic medications are pretty strong. The way that they work is similar to what I was talking about there, where you cut off the source of inflammation by impacting the immune cells. So that's the way that they work. So you can see the treatment pathway here. So in phase 1, in all patients, physiotherapy should be considered. And in all patients, people with axial spondyloarthritis should be educated about the condition. They should be doing regular exercise, or regular exercise should be promoted, and they should stop smoking. We found that these patients don't actually exist, because when people go to clinic, they go straight down there onto medication. So we find it incredibly difficult to be able to access these individuals. So what we do instead is we say, okay, the people are already taking medication. How can we improve the effects of the medication? So if they're already taking it, if we supplement that with exercise, does it produce additional benefits compared to just taking the medication by itself? So our mission really at Loughborough is to investigate the effects of physical activity on that underpinning inflammation, the immune system, and the symptom severity in people with axial spondyloarthritis. And in 2022, we published our first study in this area, which was lifestyle modification and inflammation in people with axial spondyloarthritis, a scoping review. Now, for those who aren't familiar, a scoping review, what that does is we go to all of the available research which is already published. We pull all that information together, and then we summarize it in a really concise document. We identified 45 exercise intervention studies that have ever been done across the entire world. 45 exercise intervention studies. 82% of them reported improvements in disease activity. So that's from questionnaire data. 80% improved physical function, again questionnaire data, and 73% improved mobility, again from questionnaire data. So our question would be, okay, if we know exercise is improving these symptoms through questionnaires, how is it actually doing it? So that is what we're looking at Loughborough. And from them 45 studies, when you think about this condition, it's an inflammatory condition. So surely you'd want to be looking at inflammatory markers to be able to know what's going on. Only 9 of the studies investigated inflammation, all of which only analysed CRP. Now, CRP, it's called an acute phase protein. It effectively says that inflammation is happening in the body somewhere. So it's not really that specific. And actually, in people with AxSpA, CRP is a pretty poor marker of inflammation because it's highly variable. So, for example, if you go to a clinic one day, your CRP might be through the roof, and on the next day, it might be on the floor. So, depending on where you're getting your blood sample taken, your CRP might be really high or your CRP might be really low. And also, we know that CRP does not correlate with disease activity in over 50% of people who live with axial spondyloarthritis. And actually 40% of people with AxSpA don't even have elevated CRP. So it's a pretty poor marker. And this is something we hear from in our labs all of the time. So for example, if someone's going for an MRI scan, they say, I went for an MRI scan last week, but I was feeling good that week. So the MRI scan didn't pick up anything. And so the doctor wasn't able to see what was going wrong. If I was having a flare up that week and went from a scan, actually they might have picked up something and been able to delve down into it. So that's similar with CRP. It's highly variable. So depending on where you get tested, you might be up or down. So this is where our first project, Ecstasy, was born. Don't question me on the acronym. It stands for Exercise Therapy in Axial Spondyloarthritis and Inflammation, but it's called the Ecstasy Project. And this was a proof of concept study. So it's a randomized control trial, and in research, randomized control trials are kind of the gold standard because you have a group that do a control trial and a group that do an intervention. And what we wanted to do is investigate whether 12 weeks of home-based walking, so that was 5 30-minute bouts per week, at a somewhat hard pace, so that's quite subjective, could, number 1, be tolerated without bringing on flares, 2, improve symptom severity, so that's questionnaire data, and 3, produce this anti-inflammatory response that we typically see in other populations with exercise. So what they did is we recruited 20 people from hospitals in Leicester. 10 of them were randomly assigned to a control trial, and 10 of them were randomly assigned to the exercise trial. In the exercise group, they were given activity bands, a bit like a Fitbit, and what they did is they recorded their exercise and wrote down on the diary how much exercise they were doing and any comments at all. And every 4 weeks, the individuals came back and we repeated all of our tests on them. So they came back 4 times, 0 weeks before we did any of this, 4 weeks, 8 weeks, and 12 weeks. And what we really wanted to do is see the effects of the exercise. And these people were already taking non-steroidal anti-inflammatory drugs. They weren't on biologic medication. Now, talking about the immune cells, I'll just quickly talk about one of the lab techniques because it's pretty important to our results. So the way this works is effectively, you've got these classical monocytes which are only expressing CD14, intermediates which are expressing a bit of CD14 and a bit of CD16, and these non-classicals which are expressing a lot of CD16. And remember, the ones which are expressing CD16 are pro-inflammatory, incredibly pro-inflammatory. Now, what we do in the lab is we bind an antibody. So what that does is it attaches itself specifically to what it's designed to. So we've got antibodies which will only attach to CD14, and we've got antibodies which will only attach to CD16. Now, on the other end of the antibody is a thing called a fluorochrome. Now, that's a color, essentially. So it could be green, it could be red, it could be blue, etc., etc. And the flow cytometer, what that does is it fires lasers of different colors which only excite whatever fluorochrome is present. So, for example, if we fire a blue laser at this one, it's going to only detect blue. If we fire a blue and an orange at this, it'll pick up all of those markers. And if we fire a blue and an orange at this, it's going to pick up those markers. Now, let me explain that better on the next slide, because this is actually what it looks like. So what we do is we can focus in on our monocytes based on the size of the cell. So we know exactly what size monocytes are. And then we look at which cells, so if we zoom in on that location there, which cells in there are expressing CD14, so that's across here, and which cells are expressing CD16, which is up here. And again, remember that these proportions here are the incredibly pro-inflammatory monocytes. So they're the ones which you really want to reduce with an intervention. So you've got the classicals, the intermediates, which are positive for 14 and 16, and the non-classicals, which are positive for 16, but not for 14. Okay, and this is what it typically looks like in a healthy population. Loads of classical monocytes, not so much intermediates and non-classicals. Now, onto our results. I've not progressed the slide, so don't worry. What we're expecting on a study of this length, so 12 weeks, people coming back every 4 weeks, and also doing exercise intervention, typically you get somewhere around 15% of people who drop out of the study because they either can't commit because they've got life commitments or they just don't want to take part anymore. Now, with this study, what you can see is that 0% of individuals dropped out. So that is fantastic news for us because it suggests that people want to take part in the exercise, they can do the walking exercise intervention, and actually they're bought into the study, so they want to find out more. And no flares were reported in the exercise group, which is obviously good because we didn't know if the people would get flares. Now, when we look at the two groups, what you can see as well is that they've matched pretty well. So that's what you always want in research, because otherwise what you could say is actually one group performed better than the other because it might be because they're younger, it might be because they're leaner, it might be because they're more active. So you can see that age was pretty similar. You had males and females in both groups. BMI was pretty similar, and daily steps, both of the groups were actually pretty active before they started. And don't worry too much about this. This is all our scientific jargon, but none of the differences that you can see in there were statistically significant. So that's exactly what you want. Both groups are similar. Now, onto the symptoms. This is where I'll explain this in a second, but this is the questionnaire data. And what you've got on the left-hand side of each dashed line, this is the control group. So 0 weeks, 4 weeks, 8 weeks, and 12 weeks. And on the right-hand side, you've got the exercise group, 0 weeks, 4 weeks, 8 weeks, and 12 weeks. Each dot is an individual's response. And then the lines here are the average responses. And these are called 95% confidence intervals, which we won't worry about today. Now, what you can see, disease activity, there's not really much going on in terms of questionnaire data. The lower that score, the better it is, by the way. So if it's down here, it's better. The health index as well, there's not really much going on. So none of those differences were statistically significant. But the interesting thing is, look at spinal pain. So if you look at the control group, 0, 4, 8, and 12, this scale only goes from 0 to 10. So 10 is pain as bad as it could be. And 0 is no pain at all. And you can see over the control group over the 12 weeks, their spinal pain is increasing on average. In the exercise group, we had somebody that had actually had very high spinal pain to begin with. and started to drop down. But you can see that spinal pain is coming down in the exercise group just over 12 weeks and just with walking, and that's on top of the medication that they're already taking. So that's quite promising. So now let's have a look at actually what's happening on the insides with the immune system. So CRP, that's the marker that I was talking about before, the acute phase protein that says effectively there's inflammation that's happening somewhere in the body. In the control group, you can see that the CRP is increasing. Values of 5 to 10 aren't too bad to be honest, but you can see that it's pretty much doubling over 12 weeks. In the exercise group, you can see that CRP doesn't increase, so it's maintained quite well. So that's suggesting the exercise is controlling inflammation, whereas in the control group, their inflammation is getting worse. Now, when we look at the immune cells, this is where it starts to become interesting. So the classical monocytes are the good ones, which we want to increase. The control group, you can see that their classical monocytes are coming down over the 12 weeks, which is bad news. And the reason they're coming down is because the non-classical monocytes are going up. So you can see that it's around 25, probably about 30%, and it's going up to over 40% over the 12 weeks. In the exercise group, what you can see is that the classical monocytes, the good ones, are increasing over the 12 weeks. And that's because the non-classical monocytes, those incredibly pro-inflammatory monocytes, are coming down in the 12 weeks. So it's actually the exercise, which is just, again, the 30 minutes of walking 5 times a week, is actually changing the composition of the immune system and switching it to a less inflammatory profile. Now, what you can see down here, these are 2 markers of inflammation in the blood to support this. And you can see that CRP is increasing in the control group, but coming down in the exercise group from 0 to 12 weeks. And interleukin-6 is a really pro-inflammatory cytokine is what it's called. And that's going up in the control group as well and coming down in the exercise group. So this is really reassuring. But remember that I said before, in a healthy population, these non-classical monocytes are around 10%. So you can see already in people with axial spondyloarthritis, the non-classical monocytes are around 30%, so around 3 times higher than a healthy population. So that is something that we've identified, and you can now target with interventions to try and reduce the number of non-classical monocytes, which in theory cuts off the source of inflammation, which will improve symptoms. So that's where we're going with this. Now, I'm going to explain this because if you think about exercise is also associated with weight loss. Now, that's important because fat tissue itself is a source of those inflammatory cytokines, so the interleukin-6. So if you were to see interleukin-6 come down with exercise, you might just say it's because the person lost weight. If they've got less fat tissue, then it's going to reduce the source of inflammation. So actually, it's nothing to do with the immune system. It's to do with the reduction in fat tissue. So what we do is in our statistical analysis, you can see that actually waist circumference does come down in the exercise group and body fat does come down. So what we did is we can adjust for that in our statistical methods so that effectively you say, if you rule out the body weight changes and take that into consideration, are there still differences in the immune system and inflammation when you account for those differences? And there were. So once we'd adjusted for all these differences in the body fat and the waist circumference, there were still differences in the immune cells with exercise. So the key message from that is that even if you weren't to lose weight, you could still change the composition of your immune system so that it was less pro-inflammatory. And that is a really nice message because so many people in this day and age with social media, etc., are focused on weight loss and what they look like on the outside. But what we're saying is, even if you don't lose weight, your insides are still benefiting, especially when it comes to the immune system and your inflammatory profile. So to conclude, that study, which was just a proof of concept study more than anything to make sure that people could take part in walking, suggested that supplementing non-steroidal anti-inflammatory drug therapy with walking exercise improved inflammatory immune profiles in people with Axial SpA, and that coincided with reductions in spinal pain. Importantly, the exercise was well tolerated, suggesting walking exercise can be used as a supplemental therapy for medication. And what we want to do now is explore that in the people with axial spondyloarthritis with higher disease activity who are on prescribed biologic therapies. So they're people who've got such high disease activity that have been progressed onto these relatively expensive medications called biologics. And what we know is that 50% of people on biologics discontinue their use after 5 years. So what if actually the exercise gives those people more control of their own care? It may actually improve their continuation rates of the medication and produce additional benefits. So quickly, we'll just talk about some patient feedback and a few little bits and bobs that we've been doing as well, and then we'll jump onto the questions. So this is from people that took part in that lab study. By taking part in the research program, it's allowed me to gain knowledge on AS. It's inspired me to continue with additional exercise. My family are now more patient with me and understand that AS is a disease worth taking seriously. The exercise program motivated me to push on with exercise. I used to have a gout flare-up every few weeks. I've not experienced a single flare-up during the 12 weeks on the exercise arm. So this is fantastic feedback that we're getting from the study as well. So what now? Well, this study was actually done in 2022 and 2023, and we presented the findings at the British Society of Spondyloarthritis, where it won the prize. So that just shows that was to rheumatologists, and it won the prize. So rheumatologists are interested in this. We presented it at the Midlands Rheumatology Society in 2023, and it won the prize there. And actually, we presented it at the big conference in the UK, which is the British Society of Rheumatology in 2023 and this year as well. So we presented it there as well. The next thing is the XSCB project. So what we're doing now is we're expanding the immune profiling. So the monocytes are just one type of immune cell. We're expanding that now to look at a whole host of different immune cells, which I'm happy to talk about in the discussion. And we're expanding the number of people taking part as well. So that's 40 people that are going to be taking part in that project. Now, we applied for funding for this XSCB project, and it got pushed back because essentially what happens is you go to a review board and they say if the project's feasible. Now, there was a reviewer on that board who essentially said people with SpA don't want to walk, it'll bring flares, and they'll drop out of your study. Now, our previous study, the first project, wasn't published at that point, so we didn't have any evidence to refute those claims. So that's where this NASS questionnaire comes in. So at that point, we approached NASS, who actually funded that first study. So massive thank you to NASS. And what we did is we wanted them to hand out in their e-newsletter a questionnaire that just asked which types of activities would you like to include as part of your usual lifestyle and what would prevent you from taking part in activities. And you can see there's a decent age range. Some of you might actually have done this if you signed up to it in the e-newsletter. More women than men. What you can see is that actually a lot of individuals, you could tick more than one box on here. A lot of individuals wanted to do walking, yoga or Pilates or weight training. Some wanted to do swimming and cycling. But the important thing is when you look at the what would prevent you from taking part, obviously flares and fatigue are always up there. They're always the top two. But not having enough time, not knowing enough about how much activities to do, a lack of available facilities, and access and costs were big reasons for doing it. And if you think about walking exercise, it's free to do. You can do it at any point. You can break it up. So the 30 minutes can be broken up into shorter bouts. And it's accessible to all. So the reason we research walking is that the reach of our research is much wider. More people can apply it to their lives. And we're very much patient focused with our research. Now, one of the other things that I'll quickly talk about is this UK Biobank. So the UK Biobank, I've just gone back a slide so I can explain it. It's a data set in the UK, which is so important for research because it's got 500,000 people in the database. And it's people who signed up to the project, and it's got a whole host of variables. So you've got people in there with things like cancer, cardiovascular disease, healthy populations, but then you've got variables on physical activity, symptom severity, diet, etc., etc. What we wanted to do to back up our lab study was go to the UK Biobank and do a bit of data analysis for ourselves, where we looked at the associations of obesity and physical activity with symptom severity. So what you can see here, we focused on symptom severity in people with inflammatory spondyloarthropathies, and we focused on spinal pain, fatigue, anxiety, general pain, and mobility issues. And what you can see are these comparisons compared to normal weight. So this is based on BMI. And you can see that obesity especially is associated with worse spinal pain, fatigue, anxiety, general pain, and mobility compared to overweight and normal weight individuals. We won't focus on that too much because we will talk about physical activity. But the interesting thing here is these are separated into low, moderate, and high physical activity based on volume per week. And what you can see is that people who do moderate physical activity have lower spinal pain and lower general pain than people who've got high activity compared to people who've got low activity. So what's that saying is, if you increase your activity so that you've got moderate activity, you actually benefit your spinal pain and your general pain more than if you were to do high activity. For things like fatigue, anxiety, and mobility issues, it's actually pretty similar. So that backs up that CRP data, which I presented right at the start with rheumatoid arthritis, to suggest that the biggest benefits are actually seen in the people who just do something compared to nothing. So it's not about doing loads of activity, it's just about doing a bit of activity. And this is seen here as well. So don't worry too much about what a MET is, but essentially this quantifies all physical activity across a week. So it's a questionnaire that looks at things like gardening time, walking to shops, walking around supermarkets, etc. Pulls all that information together and gives a MET minute per week score. And these lines here are what separates low, moderate, and highs to the right-hand side. And again, what you can see with spinal pain, this is 0. People who do about 200 to 300 minutes of METs per week, which is equivalent to about 100 minutes of walking over a course of a week, so 15 minutes a day maybe, they get the biggest benefits in terms of the reduction in spinal pain. And actually, if you are moderately active, that's the biggest benefit, but high activity actually increases spinal pain. So this is a bit of a weird phenomenon that people don't really think about, but actually just doing a bit of exercise is better than nothing. And actually the largest benefits are seen in those who do some exercise compared to high activity. So I just want to say a massive thank you to NASS for obviously inviting me to present this, and also for funding the first lab study. And again, I want to say a thank you to all of my funders, the Leicester Biomedical Research Centre, University Hospitals of Leicester, and the National Centre for Sport and Exercise Medicine at Loughborough University, and especially to the participants. So they weren't paid to take part, we just covered their travel expenses. So a massive thank you to them, because obviously if they didn't take part, none of this research would have been possible. So thank you very much for listening. If there's any questions at all, feel free to comment, and I'll let Zoe pick up the questions and I'll answer them as well as I can.
Brilliant. Thank you so much, Matt. That was fantastic. And it's really great because we're always hearing how people with axial SpA should be exercising. So it was fantastic to really delve into the science behind that, and particularly with the immune system. And yeah, it was great to really understand that it's having that physical effect, and why you're having those positive benefits. Thank you.
No problem.
We have had lots of questions come in. So I'm going to grill you slightly, if you don't mind, and we'll see how many we can cover. We've had a few which aren't quite in our remit that we can answer today, but for any of those that we don't cover or they're not quite in the remit, I'll come back into the comments tomorrow and answer those directly in the comments. So if we don't get to us, don't worry, we'll make sure we cover that. I think it would be great to start with a comment that Rich put in towards the beginning, where it was kind of asking about where you can really get started with activity, particularly when you are in a lot of pain. So, and if you find that perhaps when you start getting active, you then get that kickback of symptoms for a few days afterwards. Do you have any advice on kind of where you can get started?
Yeah, so people who are suffering from high pain to begin with, it's incredibly frustrating, because the last thing you really want to do is move when you've got a lot of pain. So there's two things that you can do essentially with when you've got high pain to begin with. The first one is just do a bit of exercise. So that's not necessarily load-bearing exercises like walking. It could just be just micro movements. So just stretching slightly your back or wherever your pain is to get a bit of movement into the joint, because there's a thing called synovial fluid, and synovial fluid is effectively the lubricant of the joint. So in knees, hips, in your back, you've got this synovial fluid between the joints. And what happens is over time, if you're inactive, the fluid isn't really effective. So it's not lubricating the joint properly. And if you can just put a bit of movement into the joint, effectively you can improve the composition of that synovial fluid, so it lubricates the joint more. Now, one of the things which is really good for people with high pain is hydrotherapy, so aquatic exercises, because effectively it's taking all the weight off the joints, so you're able to stretch your joints more, etc. One of the issues with hydrotherapy is the access to it, which we can get onto. The other option is to go to your rheumatologist, and I know we've talked about lifestyle modification, but try and get a medication which relieves your pain symptoms, which will then allow you to do the exercise which will then allow you to manage your symptoms. So they're really the two options for high pain. I know it can be frustrating. And then if you're doing exercise and that brings on pain, the general advice is listen to your body. So if it's bringing on pain, scale it back a little bit. So if you're doing 10 minutes exercise and it brings the pain on, scale it back, do 5, see what that feels like. Just keep scaling it back. Once you feel okay, progress it slightly. So don't make massive jumps. If you're just doing a bit of stretching, don't then just suddenly start running. Listen to your body and just progress it slightly, and just listen to your body.
That's brilliant. Thank you. And yeah, really great advice. Lindsay asked, this question leads on quite nicely. Lindsay asked about, in terms of the 30-minute chunks of exercise, did you find that they had to be done as a 30-minute chunk, or could they be broken down through the day? Is that still just as beneficial?
Yeah, so it can be broken down. We actually told people on that study that they could break it down. So rather than doing 5 30-minute bouts across the week, or let's break it down to 30 minutes a day, you could break that 30 minutes a day into 10 3-minute bouts, 3 10-minute bouts. So for example, some of our people, one of them worked in London, and he just got off the tube one stop earlier, and that's how he was getting his exercise, and that accumulated up to 30 minutes across the course of the day. And other people would just walk in their dog for 10 minutes, and then they'll come back, and then they'll do the other exercise at the end of the day. So you can break it down and you still see the positive benefits.
Oh, brilliant. That sounds really good. And we had a bit more of a question around that as well, in terms of if there was a specific program that people followed, or because I know you mentioned kind of that it was kind of moderate intensity. How did you measure that? Was it based on heart rate or just how they felt?
Yeah. So I didn't have enough time to go into that in detail. So what happened was, on their baseline visit, the individuals were put onto a treadmill, walking, and they walked, and what we had is the Fitbit on them and a heart rate monitor. And there's a thing called an RPE, a rating of perceived exertion scale. Now, what happened is we got them walking for 30 minutes on the treadmill. And every 5 minutes, we asked them for their RPE score. And a score of 13, which is somewhat hard on an RPE scale, corresponds to a heart rate of 130. So a score of 14 would be 140, a score of 15 would be 150, and so on. And what we did is, if their RPE score was falling below 13, somewhat hard is what we wanted, we'd ask them to either increase the speed or increase the gradient. And what we'd look at is the heart rate response to that. So we're just getting the individuals used to walking at a pace of somewhat hard. Then what they did is they took that information, and the people who were on the exercise trial then implemented that at home. So they got given the Fitbit, which had obviously the heart rate data, and they were given the RPE scale to take home with them. And when they went on the walk, what they just did is they went down the scale, said, where am I walking at? What's my heart rate and my distance? Can I increase my pace, or can I increase my gradient to get up to that level? And they got given an exercise diary to fill in every time they did the exercise, which said the total distance, the heart rate, and the RPE of the exercise. And then any comments for not doing it, which might be something like, it's icy outside, so I didn't feel comfortable exercising. So that's how it was done.
Oh, brilliant. That's really helpful. Thank you. And we've had a couple of questions around fatigue being a bit of a barrier to exercise. I wonder, did you kind of measure the impact on fatigue, or did the research sort of show that actually over time, by gradually increasing it, you're able to improve fatigue at all?
Mm-hmm. So fatigue was picked up in our questionnaires. The exercise did improve fatigue slightly, but to a point that it didn't come out as statistically significant. The reason being, in research, if you've got a sample size of 10, which was in the exercise group, if you've got high variability in fatigue, you can't really see any differences over the course of the time. So one of the reasons we're increasing the sample size to 20 is it increases the power of the statistical analysis. So you start to reduce the variability in the data set. One of the things that obviously we have done is that biobank analysis. So the biobank did look at fatigue as one of the primary outcomes, and it suggested that moderate and high activity were associated with lower fatigue than low activity. But then you've got the argument of it's a thing called reverse causality. So for example, are those people who, it's like the chicken and the egg, are the people who are moderately active, they have lower fatigue just in general, which allows them to do the exercise, or is the fatigue contributing to the exercise in the first place, if that makes sense? Mm-hmm. So it's a bit like the obesity angle, for example, looking at mobility, especially. Are people who are lean able to exercise more which obviously improves their mobility, or are they immobile in the first place, which contributes towards the obesity? So that's one of the things that we need to look at in the future.
Oh, that would be really interesting to unpick that, definitely.
Mm-hmm.
I'm aware we've still...
Anecdotally, just talking to people in the lab, we didn't actually measure this, but a lot of people who just got outside exercising, so walking the dog in green spaces, they commented on actually the fatigue and how exercise, just getting outdoors, was good for their mental health and obviously improve fatigue. So it's something that we're going to measure in more detail going forward.
Oh, that would be really interesting. I'm aware of the time. Are you okay to hang on for another sort of 10 minutes, see how many we can get through? Great, thank you. So we had a question from Edward that was asking about more about kind of the radiographic progression of axial SpA and whether exercise can delay that, if there's much research into that, or if there's like particular exercises that have been found to help with that.
Yeah, so we don't focus too much on that because it's more clinical care, whereas we're research focused, and we do have access to an MRI scanner, but we didn't do, it costs too much essentially for us to do it in that study. Now, there's these things called syndesmophytes, which you might have heard of, and effectively what they are is on the spine, that process which I talked about where you get the immune cells kind of attacking the area, you get calcification of the spine. And the syndesmophytes are like these bony little spurs that come out. And the studies that have looked at syndesmophyte progression, so that's the number of these bony spurs on the spine, and they've looked at that through radiographs. Exercise can't halt it, but it can delay the progression of them. So when people say, can exercise halt the progression of AS? It can't halt it, but it can slow the progression. And that has been found on exercise studies, especially with swimming. But that's been done by other research labs. And I'm happy to share that research if you're able to email it out or something.
Yeah, I'm sure that would be great for everyone to have a little read of, definitely. And that leads on very nicely to my next question, which is we've had a few questions about different types of exercise and whether they're beneficial, so kind of land-based or hydrotherapy. A few questions on kind of higher intensity exercise as well, if that's particularly beneficial, like weightlifting. Do you know if there's much kind of research into that?
Yeah, there's a group in Sweden that have been doing high interval exercise training. I'll just touch upon the swimming first and hydrotherapy. So the rationale behind that, which I touched upon before, was that you essentially reduce the load on the joints, which allows you to stretch more. And also you've got the natural resistance of the water, which helps build up your muscles. Hydrotherapy does have its benefits. So if you're doing that and are enjoying it, carry on with it, because that's one of the key things. Do something that you enjoy because you're able to implement it into your life. With high interval training, there isn't much. There's a group in Sweden that have looked at this, and they presented it at the British Society of Rheumatology a few months ago, where they actually found it to be quite beneficial. So one of the concerns in the official guidance for AxSpA is that if you're doing high intensity exercise, can it actually damage the joint? So that's one of the big concerns, but actually that group didn't find it. That's one study though. So I'm happy to share that research as well. In terms of resistance exercise, so weight training, it is good because effectively what you're doing is you're building up the muscles to support the joint. But with any exercise, what you want to do, like I said before, is to listen to your body. So if you're doing exercise and it's making it worse, don't do it. Scale it back a little bit. And also do exercises which you enjoy, because you're more likely to actually incorporate that into your life. So if you're doing a walking intervention and you're not enjoying it, then chances are you're not going to do it in 1 year's time. So do something that you enjoy, which could be something like stretching or yoga exercises as well.
Oh, brilliant. It's like the age-old thing of New Year's resolutions where people get started on something because they feel like they should and then just never keep it up because it's just not enjoyable.
Or they get a new device and it stays on their wrist for 6 weeks and then it goes in the drawer. So it's a bit like that.
Yeah,
as well.
Absolutely. Yeah. Okay, brilliant. And I'm just having a look through the questions, seeing which ones we haven't covered yet. We did have a question beforehand from Alana, actually, who was asking, you've touched on a little bit in terms of the higher activity group and where they sort of paradoxically can get a little bit more symptoms, because she said that she's finding it difficult to judge the right amount of exercise and most days gets around 8,000 to 10,000 steps a day, but she's still very stiff in her joints and has little flexibility. So would you be able to talk a little bit around kind of how much is too much and that sort of thing?
Yeah. So which exercise is that she's doing? Sorry, what type of exercise?
That was for walking.
Yeah. So
doing up to 10,000 a day.
yeah, so that can be a frustrating thing in the fact that you feel like you're hitting the recommendation, so that arbitrary 10,000 steps, but actually your symptoms are still bad. Now, one of the things with walking, it's very, very good for helping your muscle mass in your legs, but it's also very, very good for your cardiovascular system. So I'd carry on doing that. But the one thing that walking isn't very good at is flexibility in your back. So if you imagine when you're walking, your back's not really moving too much, you're pretty much upright, and all the exercise coming through your lower legs. So you've got the benefits of walking, but what you could do is try and supplement that walking with a different type of exercise. So for example, if you're walking 30 minutes a day, which is about 8,000 steps, you could walk for 25 minutes a day and do 5 minutes of stretching or yoga or Pilates, which would then get the flexibility into your joints. So you're supplementing your kind of cardiovascular exercise and your muscle building exercises with a bit of stretching as well, which should relieve the flexibility issues. So that's one thing that you could try.
That's great. That is super helpful. Definitely getting that balance there. And I imagine if Jamie or Jeff from Yoga for AS are watching, they quite often join our live streams. They'll be agreeing with that there, definitely.
Yeah. Well, that again is about getting flexibility in your joints and moving around that synovial fluid to lubricate joints. And
absolutely.
That's one of the things with sedentary lifestyle. So if you sat at a desk and you stiffen up, that's one of the reasons, because you're not really moving those joints.
Yeah. Well, we all feel that first thing in the morning as well.
Yeah, the morning stiffness, yeah.
Brilliant. I'm just having a quick scan through. I think we've covered most of the questions that we can at the moment. We did have one over on Instagram we haven't covered yet, which was Amy was asking about if in the study you described, was there a similar reduction in peripheral enthesitis pain compared to spinal pain?
In the study which we did?
Yeah.
No, so we didn't measure that. So one of the things that we did do is we did a few functional tests. So the functional tests which we did do is called a sit-to-stand test, which can assess your peripheral joints, because effectively what you do is you sit down on a chair that doesn't have any arms on it, put your arms across your chest, and then you go from a seated position to a standing position 5 times as fast as you can. That's called a sit-to-stand 5 test. Then the other one which we did is called a sit-to-stand 60 test, and it's how many times can you do that within 1 minute. Now what we found on that was there's definitely a learned effect of the. So what I mean by that is the control group and the exercise group both improved in the test because they got used to doing the test. So that was a functional test which we did in that one. We didn't look at peripheral stiffness via a questionnaire or whatever, but that is something that we've actually included on the next study. So we will be doing that. The questionnaire packs for the next study are massive. So it's one of the. We always get patient feedback on the studies, and it's one thing that we're quite conscious on the next study is that we might be actually asking too much. So we'll wait to hear about that. But yeah, we're looking at peripheral stiffness on the next one.
Oh, brilliant. I imagine with most research, it is as soon as you complete something, you kind of come out almost with more questions than you started with as you dig deeper.
Well, also as well, this was our first lab-based study in people with axial spondyloarthritis. So based at the end of our studies, we always do a PPI group, so a patient feedback group, and their feedback is then massively important because it then we use that to actually implement into the next project. So for example, on the first study, there was actually going to be a 20-week visit. So they go home for 8 weeks, do whatever they want and come back. But actually people said that's not useful because the exercise intervention stops at 12 weeks. You don't know what they're doing for the next 8 weeks. The information actually isn't that useful. So you end up scrapping the 20-week visit. So that's an example of where the patient feedback is actually really important. So at the end of the day, people have got busy lives around the research.
Yeah, that's super, super helpful. Brilliant. I think the final question we've got is from Caroline, which is asking about if you know if sort of the timing of exercise makes any difference, because often sleep issues and pain in the early hours can be quite difficult then to start exercising. Do you have any sort of thoughts around that?
So that's interesting. And I'm not aware of any research that's looked at the timing of exercise. So for example, if you're in the morning, afternoon or evening, the people who took part in our study could do it at any point in the day. One of the questionnaires did assess morning stiffness because that's where the stiffness and fatigue is the worst, and some people can take hours to get out of bed, for example, because of the morning stiffness. but it's not something that I'm aware of, or I've heard of any research that's been looking at the timing of the exercise. So the rationale behind that, I'm guessing, is that if you're suffering from stiffness the most in the morning, if you can target that time of the day with the exercise, you get the biggest benefits. So that is something that's quite interesting, but we might have to look at in the future. So thank you for that.
Planted a seed there, so watch the space, Caroline. Brilliant. Well, that has been fantastic, and hopefully we've covered everyone's questions, all the ones that we could, that are kind of in the remit of tonight's session. So yeah, if we've missed any of them, what I'll do is I'll come back, I'll go through all the questions tomorrow, and just anything that we've missed, if you're happy for me to, Matt, I'll email those over to you, and then I can reply directly in the comments for everyone. That'd be fantastic. Was there anything else you wanted to add, Matt? I know you had a bit of a grilling this evening, so I appreciate that.
It's all good. Yeah, I just want to thank everybody for showing up, obviously listening to the research that we've been doing at Loughborough. If you ever want to ask me any questions, I'm not a rheumatologist, I'm just a researcher, but you can just search my name in Loughborough University, you'll be able to find my email address on there. And obviously I want to thank NASS as well, whilst we're here, for funding the study and for inviting us to obviously talk about it as well.
Brilliant. No, thank you so much. It's such important work, and yeah, it's obviously lots of questions tonight, so lots of interest in it as well. So it really shows the benefit. So thank you for being interested in this area of research and really getting stuck in an area that doesn't, as you said, doesn't have much research yet. So yeah, going to be really beneficial for people.
100%. The research really has only just begun from Loughborough side into the area. And like I said, we're going to really expand that immune profile in the next study, which will help people, because then we can focus on lifestyle modification, which targets the cells of interest, but also pharmacological companies might be interested in that because they might start to target themselves as well with medications. So it's really developing.
Oh, that'd be fascinating. Wonderful. So thank you again, and thank you to everyone who's joined us live as well. It's been really great to hear all of your experiences, get all of your questions as well. So thank you so much for joining us, and thank you to anyone who's joining on catch up. And what I'll do, as I said, I'll answer any extra questions in the comments there as well. Before we finish up, I'll just share our next live stream is going to be on Wednesday, the 11th of September, taking a little break over August because we know lots of people are away on holidays. So on the 11th of September at 1 p.m, I'll be joined by Ian Young, who has previously run lots of somatic movement sessions. So great for this topic, focusing on physical activity. And he's going to do a somatic movement session, particularly for people who aren't able to get down onto the floor to exercise. So it should be nice and accessible for everyone as well. So hopefully everyone can join that. But yeah, thanks again, Matt. Really fantastic, and looking forward to hearing more about the research in the future as well.
Thanks very much.
Take care, everyone, and see you in September, hopefully.